I'm Paul Sugarbaker. I'm the editor of the textbook and video atlas of cytoreductive surgery and perioperative chemotherapy. I'm here with Kurt van der Speeten from Genk, Belgium, and we're looking at a video on the management of rectal cancer in patients who have peritoneal metastases. Kurt, there are obviously many different approaches to this patient. Could you outline for us what the management plan for a young woman like this with peritoneal metastases in Genk, Belgium?
To be very honest, my answer to that question has changed over time. 10 years ago, I would not have offered these patients cytoreductive surgery and HIPEC. My initial results with treating them were actually quite bad. All of them recurred as well intra-abdominally, diffuse, as systemically. So I didn't do them for a couple of years, and then I realized that I stopped doing them for the wrong reason, being that these patients, they ended up at my office when they have had 5 or 6 lines of chemotherapy and were basically chemo-resistant to all treatment, surgical and non-surgical. Now, as matters have evolved and the concept of HIPEC and cytoreductive surgery has become more known to our colleagues, medical oncologists, we see them at an earlier stage of their disease. So we see, like this patient, actually a native patient with primary rectal cancer without any prior pre-treatment. So she is an ideal candidate for this treatment, being cytoreductive surgery and HIPEC. In my hands, she would get neoadjuvant radiochemotherapy, then cytoreductive surgery with HIPEC, followed by full adjuvant chemotherapy. And this has definitely improved our results.
Do you think, Kurt, that the neoadjuvant radiochemotherapy interferes with the HIPEC in any way? In other words, you're treating an irradiated area with HIPEC. Do you think that's dangerous?
Well, we didn't see any differences in morbidity or mortality in these patients. I'm mostly worried about the reason why they need it is that these patients are at risk later on as well of local disease, as local recurrence, as of systemic recurrence. So we need to do it the right way.
Now, it's not uncommon for a colorectal surgeon to begin a laparoscopic rectal cancer resection and they encounter peritoneal metastases. What would you advise at this point in time for the colorectal surgeon to do in that particular situation?
Well, he should do a proper exploratory laparotomy without dissection, so that he can give us a good operative report on the extent of the disease. But next to that, I would suggest him to abort the procedure. We all know this concept of peritoneum as first line of defense, so I wouldn't do a resection at that time. If the patient is obstructed, I might advise him to put in a diverting ostomy, but definitely not do resections, and refer the patient to a center which is experienced in treating peritoneal surface malignancy.
And that would go for colon cancer patients with peritoneal seeding as well as rectal cancer patients with peritoneal seeding?
I think this is a general recommendation to surgeons, and actually our efforts are taking on as more and more of these calls are coming in from a surgeon, a community surgeon, seeing these patients during their operation. The first thing is do not harm the patient, as we have all learned.
Kurt, in the video, we've gained a wide exposure using a fixed retractor, and then we've begun a perihepatic dissection. Part of that was this division of the pont hepatique, or hepatic bridge. Is that important in cytoreduction?
I think it's mandatory. Even in patients without any evident peritoneal disease in the upper abdomen, when you open up this hepatic bridge, quite often you will find that it is a safe harbor for peritoneal nodules, and it's actually a quite common site of recurrence if you don't clean them up. It's similar to the recessus, which is under the caudate lobe, which you see later on in the surgery, which is open to the same risk. So that's also needs to be checked, and if necessary, the peritoneal surface needs to be removed there.
So even if the abdominal exploration doesn't obviously show disease in that umbilical fissure, you would always open it up.
As a routine, we
open it up.
As a routine, we open it up to have a proper exploration. It's actually part of the exploration of the abdomen.
Now, in exploring the abdomen on this young woman, it was remarkable that the small bowel, despite the large amount of tumor around the other parts of the abdomen, we found the small bowel to be completely clear of peritoneal metastases. How can we account for that?
Well, there are both physical and biological reasons for that. First of all, physical, that as the small bowel moves around, contrary to the colon, it is in most cases devoid of peritoneal nodules. The second thing is that the biological behavior of these colorectal tumors in a lot of cases doesn't end in peritoneal nodules on the bowel. It's something totally different when you compare this to peritoneal mesothelioma, where you, in a lot of these patients, you will see a fine but very diffuse layering of the small bowel. So that's a biological difference between these tumors.
Now, quite the opposite was seen above the liver and underneath the right hemidiaphragm. Why does the disease occur in such large volume at this site?
First of all, it is quite known that these diaphragmatic surfaces are covered with diaphragmatic or lymphatic stomata, which are an open way for tumor cells to penetrate the peritoneum. Next to that, the normal flow of the peritoneal fluid goes in a clockwise way throughout the abdomen, and it's one of the most affected regions by peritoneal metastases for this reason.
What about the ovaries? The ovaries in this patient were extremely large, 15 and 20 centimeters in diameter. Why was the rectal cancer growing so fast within the ovaries?
In female patients, these ovaries, every month, they present a large raw surface which is highly vascularized and an ideal place for tumor nodules to penetrate. So they are the first breach, they are a kind of natural breach of the peritoneal covering which occurs every month. And that's the reason why in quite a lot of these patients it's the first and sometimes only site of peritoneal disease.
We performed in this patient what I sometimes refer to as centripetal surgery. We kept going around and around the parietal peritoneum first and then coming on into the visceral resections. How do you approach these patients?
I think it is a very important concept for two reasons. The first being very practical, that if you got stuck at some region inside the abdomen and it starts bleeding, it is a better idea just to stop for some time and move on and try to get at it from a different angle. And you try to encircle your enemy from different sides. And that way it's easy, it's helpful as to the dissection, but also to reduce the blood loss in these patients. So I think it is an important concept, especially in the patients where you have a large involvement of the anterior peritoneal surface. It's usually it's very helpful to do this as a centripetal surgery and not go in straight forward. Just make a small peritoneal opening, see what you're up to. If it is large involvement, you go around it.
Doesn't it frighten you as a surgeon to remove virtually all of the parietal peritoneum? Do you think that dissection is compatible with a good long-term high quality of life?
It definitely is. Contrary to intuitive thinking, it doesn't influence these patients' quality of life. It's actually more the extent of the visceral resections which will influence the quality of life in these patients. So I don't think it's very important the size or the amount of peritonectomies you are doing. From pharmacokinetic studies, we know that A large or a small peritonectomy doesn't influence the plasmatic transfer of chemotherapy, so also to the systemic toxicity there is no difference between patients having a large or a rather small peritonectomy.
In this procedure, almost all of the dissection was performed with the ball tip electrosurgery used on pure cut at high voltage. How do you approach this dissection?
We use the same tool, but we sometimes use bipolar scissors. Actually, what we do mostly is that in very mucinous tumor with a mucinous layering, we use the ball tip. If it is quite dense nodules, we go for bipolar scissors. But there is a variety of tools which you can use for getting the tumor out.
How about in the pelvis? Most of the dissection in the pelvis is with ball tip, or you use the bipolar scissors?
We use the bipolar scissors.
You don't find that you tend to damage those vital tubular structures such as the ureter with the bipolar scissors?
No, I'm not worried about bipolar. Actually, I'm more worried about the high voltage for the nerve plexus than with the bipolar. It's actually one of the reasons why I start doing it as a routine in my colorectal surgery. I use bipolar, so it's useful in this kind of surgery as well.
Now, another challenge sometimes in the pelvis is the uterine arteries. How is it that you approach the uterine arteries? They can be a big problem in this pelvic dissection.
They especially are in very bulky disease. So once again, the answer is a centripetal approach. Try to get it at it from different angles. Go widely into the vesicovaginal septum. Do a wide dissection on the posterior side and make sure that you have seen all structures before you start ligating them.
When we transected the vagina, we were careful to hold up on the posterior aspect of the vagina in order to try and remove all of the peritoneum in the cul-de-sac. Would you tell us about your approach to peritoneectomy deep in the pelvis?
I think this anterior approach to the deep pelvis is mandatory. If you try to go from the posterior side, you will end up inside the tumor. So you just have to find this thin layering of non-vascularized tissue between the posterior side of the vagina and the peritoneum, and you just follow it under the cul-de-sac, and that's the level of your transection. So I think it is important to enter this plane just posterior to the vagina because it's the easiest and the less bloody way to get under the level of the cul-de-sac, and at the same time you can then define the level of transection.
Now, in this patient, the colorectal anastomosis was quite deep in the pelvis, and we elected to do a diverting ostomy. What are the indications for a diverting ostomy in this type of patient who's had a major cytoreduction, who's had the HIPEC? When do you need to perform a diverting ostomy?
Our practice has changed for that. At this point in time, my recommendations would be that if you have more than one colonic anastomosis or what I would call unprotected low rectal anastomosis, so you're not able to put on a second layer of sutures, then I would go for an ostomy. We know from animal studies that the incidence of leakage after HIPEC in rectal anastomosis is quite a bit higher than after a normal rectal resection. So there is a wide indication for putting in diverting ostomies in these patients.
Now, we used not only HIPEC in this patient, but she was young and she'd not had any prior chemotherapy, so she also had a full dose of EPIC 5-fluorouracil, and we brought her 5-FU dose up to 2 grams per meter squared. Does the use of EPIC have an impact on ostomy, no ostomy, in your opinion?
It doesn't have an impact on my usage of ostomies. What we do at this time is if the patient had no heavy prior treatment, if the procedure was quite straightforward and the patient is in a good general condition, we always try to add EPIC because I'm convinced that it adds to the benefit of the procedure. but we have to take into account that it also adds to the toxicity. So when we can predict a quite low toxicity, we do the EPIC.
In this patient, we did an end ileostomy, and then the proximal rectum was closed and dropped back into the abdomen because we planned to do a second look ostomy closure. How do you approach that problem?
We would probably go for re-anastomosis, and we do what I call a terminalized loop ileostomy. So what we do is we bring the loop of terminal ileum out, and we put a stapler, TEI stapler on top of that, so that there is no overflow of intestinal fluid into the distal limb. It gives us the advantages of both an end ileostomy, no overflow, and the advantages of a loop ileostomy, that we can re-anastomose without having to do a full laparotomy.
So, but it means that you have to do a second anastomosis at the time of the surgery.
No, you only have to do the anastomosis of the small bowel and then just drop it in again and close the abdomen, because the rectal anastomosis is already done at that time.
Right. Now, in this patient, we did both a right colon resection and a rectal resection. So
I would still do both colonic anastomosis, so as well the rectal re-anastomosis as the ileocolic re-anastomosis, and put on top of that or in front of that.
Put in front of that.
A terminalized loop ileostomy.
Stripping of the undersurface of the right hemidiaphragm went well in this patient, but it doesn't always go well, especially when there's a moderate to large volume of high-grade tumor, and sometimes we have to dissect through the right hemidiaphragm and into the pleural space. When you do that, what is the implications of that for the patient?
What we would do is we leave the diaphragmatic breach open, and before starting the HIPEC, we would put in a chest tube and use it as an additional outflow catheter, and include a pleural cavity in the circuit of chemotherapy circulation. So I would not close primarily. I would leave it open and put chemotherapy inside the pleural cavity as it is contaminated by tumor. And actually, if you breaching the diaphragm, you will see that in a lot of cases the tumor is really growing full thickness into the pleural cavity, especially on the tendinous part of the diaphragm. You can see this full thickness. It's one of the few places where you see full thickness invasion.
I'm happy that we did not see any liver involvement or parenchymal liver involvement in this patient. We did have some nodules on the surface of the liver, but what are your thoughts about a major cytoreduction such as this combined with liver metastases?
If it is easily removable liver metastases, I would go for it. I would not go for a full hepatectomy or a formal hepatectomy, because it would definitely extend the amount of surgery, and I also would predict that there would be a greater transfer of chemotherapy solution into the plasmatic compartment.
Okay. Now we removed some other structures, spleen. Do you have any misgivings about splenectomy in this type of patient?
No. It actually doesn't add to the morbidity or mortality of this procedure. And in actually all patients who have large omental involvement, it's almost in every time it's impossible to separate it from the spleen. The tumor gets inside the small fissures of the spleen. So it is a better idea to remove the spleen with little blood loss instead of trying to remove it from the peritoneal covering of the spleen.
Now, sometimes these patients don't have such extensive omental metastases, and one could clear, at least visibly clear, the omentum with what's called an infracolic greater omentectomy. Do you ever do the infracolic greater omentectomy?
No, we always
Never.
do a full omentectomy. Actually, if you are treating patients with ovarian recurrent peritoneal metastases, in which the previous surgeon did one of these subcolonic omentectomies, one of the most involved areas is always this residual omentum between the colon and the greater curvature of the stomach. So I think it's mandatory to do a full formal omentectomy.
This patient did have a small amount of involvement of the gallbladder, but sometimes you don't. Do you think it's important to remove the gallbladder if it appears to be negative, or should you just leave it behind?
Well, I learned it the hard way.
Oh, really? Okay.
That I had 2 of these patients who developed cholecystitis due to ischemia, due to the duration of the procedure. So it's always a very bad feeling after this very extensive procedure, which went well, that you have to go back for doing a cholecystectomy 5 days later on because the patient is septic, which is something which has nothing to do with the site reduction on itself. So it is a routine now to do a formal cholecystectomy. Actually, in all procedures we do in our department, taking longer than 5 to 6 hours in the abdomen, we take out the gallbladder.
Really? Okay. So not just HIPEC patients, but extensive...
retroperitoneal sarcomas or all extensive surgery, taking more than 5 to 6 hours. The risk of distal ischemia is too high, and it doesn't add to the morbidity to do the cholecystectomy.
No. With that big exposure, it takes 7 to 10 minutes, and it's very safe, isn't it? Yes.
And the surgical resident is very happy with it.
Yes, that's true. The assistant has a more active part of the surgery. Yes. Now we used an open technique. You saw us create the vapor barrier using the smoke evacuators. How do you do the hyperthermic intraperitoneal chemotherapy so that the environment is protected?
We also perform an open technique. We have this kind of homemade vapor screen which we put on top of that, and I think it's mandatory to use these smoke evacuators. I think they are the key to doing this kind of surgery. It also raises the question about doing open or closed techniques. I think clinical series don't show any clear differentiation between these two as to results. We have seen in our pharmacokinetic studies that maybe patients with a very contracted and small abdomen, they might benefit from this closed technique as the intra-abdominal pressure is higher. So we think, or we hypothesize, that the penetration of chemotherapy might be slightly better if we can do it with a closed abdomen at an increased pressure. So that there is actually place in one department for doing both techniques, depending on the kind of patient you have before you.
Do you use the manual distribution of the chemotherapy during the HIPEC?
Oh yes. I think it's one of the, actually in the beginning we didn't do it enough, and we saw, for instance, recurrences below the liver, classical
back of the liver,
back of the liver. So I think you have to do it. It's one of these things. We actually at one time we tried even with a methylene dye to see how long it takes to have a very good distribution of the fluid. And it's amazing, it takes you up to 15 minutes of vigorous manual moving around in the abdomen before you have a uniform layering of the dye on the surfaces.
And that's even with the open technique, with manual distribution?
Even with the open technique. So I think it is an important issue.
Of course, some people in the operating room, I think especially our nurses, are worried about the open abdomen and the possible contamination of the environment. What do you tell your operating team about their possible risk with the open technique?
Well, actually there is quite a bit of literature on that, and all of it is actually quite uniform in its advice. First of all, the chemotherapy doesn't get into aerosol in a substantial amount, so there is no risk there. Actually, the biggest risk inside the operating room is the electrocoagulation vapor. So once again, the smoke evacuator is the one crucial element which needs to be there for trying to limit the environmental hazard to the operating room staff.
This patient had her right diaphragm stripped, and the left diaphragm was dissected a small amount in and around the spleen, but it was not a complete peritoneectomy. What are your indications for placement of chest tubes in this group of patients?
Actually, I put in a chest tube in all patients who have a diaphragmatic stripping.
Okay.
If I have to do a full diaphragmatic stripping, they all get a chest tube because most of them will develop subsequent pleural effusions. So better do it at the time of surgery.
Kurt, we send all of our patients to the surgical intensive care unit. Are there any special considerations while your patient's in the SICU?
Well, one of the things we have learned is that if you have an indication of a fistula or a leak, you cannot sit on it in these patients, whereas in a normal colorectal procedure and you have a limited leak without clinical implications, you can sometimes just sit it out, leave the drain in. In these patients, you have to go back and go back early. So all fistula is a reason to go back to the operating room. That's one of the main lessons we've learned. Other things is that as surgeons we have to become accustomed to hematotoxicity, which is not something which we have been trained with. So in our initial experience we underestimated some thrombocytopenia, some neutropenia which we have seen, and you have to be up and ready for that. So that's the point where you need to call in your medical oncologist even in the ICU to help you out.
Now, if you have a leak at the low colorectal anastomosis, do you always have to take that anastomosis down and exteriorize the sigmoid colon? Or can you be conservative and try and preserve that anastomosis, say with a diverting ostomy?
In most cases you will come away with doing a new double suturing layer and putting the ostomy if you haven't done yet. I haven't taken so far an anastomosis down completely. No. Not even in the patients with rectal cancer and the neoadjuvant radiochemotherapy.
When the patient reaches the nursing unit, are there special considerations